So there have been several perioperative trials that have been using Enfortumab vedotin and Pembrolizumab in bladder cancer. The first one that was reported at ESMO 2025, this was a trial called EV303 or Keynote 905. This trial enrolled patients with muscle-invasive bladder cancer and also ineligible for Cisplatin, meaning they had neuropathy or hearing loss, or it enrolled patients with who were ineligible for Cisplatin, meaning they had peripheral neuropathy, decreased renal function, or hearing loss that made them ineligible, and either randomized them to Enfortumab vedotin with Pembrolizumab or cystectomy alone. And what they found was an important event-free survival difference of these patients at 2 years between the patients treated with EV-Pembro and those patients treated with cystectomy. Interestingly, there was a pathologic complete response of 57% in that patient population. Fast forward to GU ASCO this year, we saw also a perioperative trial called EV304 or Keynote B15 that was also read out and showed an improvement in across chemotherapy, showed an improvement across cisplatin eligibility. So these were patients who were eligible for cisplatin. They were randomized to Enfortumab vedotin and Pembrolizumab versus a platinum-based chemotherapy. What they showed was also an event-free survival difference in patients treated with Enfortumab vedotin and Pembrolizumab. There too, we saw a pathologic complete response of about 56%. So having that very consistent pathologic CR rate shows us that EV Pembrolizumab is a good option for across cisplatin eligibility for muscle-invasive bladder cancer. Now, the approval, at least in the U.S., is currently in the cisplatin ineligible patient population. We will likely see an expansion of that label now in the next few months, given the B15 results that we saw at GU ASCO this year. I think it's a really important time to think about any patient with muscle-invasive bladder cancer to consider using Enfortumab vedotin and Pembrolizumab, but also raises a lot of questions of who needs post-operative treatment. In these trials, they did have continuation of both Enfortumab vedotin and Pembrolizumab. We had a recent approval based on the IMvigor011 trial of ctDNA positive disease treated with atezolizumab. And so I do think that thinking about minimal residual disease, ctDNA positivity in bladder cancer is important. And when we're in the post-op setting, trying to find those patients at highest risk for disease recurrence in order to continue their ongoing treatment pressure. I think there will be some sequential approaches once patients then develop metastatic disease. Depending on timing of the development of metastatic disease, we may or may not want to re-challenge with EV Pembrolizumab. If it's very close to the finish of their prior therapy, they might need to consider other options.